This time our topic is development and psychopathology. So how do we understand human development? Well, views on this have changed quite a bit over the centuries. In the 16th and 17th century, the view was that a fully formed person is contained in every sperm, not egg, but sperm, and that development was really equivalent to physical growth. Small people get larger. That's it. Our conceptualization of human development in terms of phases or stages is relatively recent. Here are some overarching developmental patterns. Ontogenesis, which means individual development, is epigenetic. Epigenetic means unfolding according to a basic plan in a sequence of qualitatively distinct phases, such as infancy, toddlerhood, adolescence, that are marked by increasing differentiation, that is, specialization and sophistication, increasing individuation, and increasing self-regulation. Now, this overarching plan applies to many forms of development, including the development of language, the development of cognitive abilities, social and emotional skills, and physical growth. So let me give you an example in terms of language development. So we said that it's unfolding according to a basic plan, and in language development, the plan, in quotes, is that infants begin to make sounds, and those sounds are reinforced by those in their environment, and they become words, imbued with meaning. And then words are strung into sentences, and communication becomes more sophisticated. You can see this happening in a sequence of qualitatively distinct phases. So again, infants are making sounds, toddlers are saying words, and adolescents are writing and talking and thinking in whole sentences and paragraphs. We see this pattern marked by increasing differentiation, increasing specialization. As vocabulary increases, we use words, many more words for very special purposes. This vocabulary becomes more sophisticated, more elaborated. We develop individually. No two people develop exactly the same vocabulary or speech patterns. And overall, we become increasingly more self-regulated, meaning that we're doing more for ourselves and we are less dependent on our caregivers. What is psychopathology? The word psychopathology has two parts: psycho meaning mental, pathology meaning illness. According to the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, psychopathology is thought of in terms of mental disorders. And these are defined categorically according to certain diagnostic criteria, which involve the presence of some number of specific signs and symptoms. Now, a sign is something that can be observed by somebody else. A symptom is something experienced by the client that may or may not be observed by someone else. So in the DSM, we have categories of mental disorders, and people meet diagnostic criteria if they have certain signs and symptoms in a specific period of time. But there are other ways of thinking about psychopathology. In your article by Cicchetti, he suggests that another way to think about this is to think about mental illness as an extreme, either extreme, on a continuum. So we can think of a lot of different continuums of human experience, behavior, expression. For example, the expression of emotion can be thought of as on a continuum, with either end, either extreme, being potentially pathological. Underexpression of emotion or overexpression of emotion could be viewed as abnormal. Cicchetti also notes that you can think about pathology in terms of shades or degrees or levels of severity. It's not that you have a disorder or you don't, but there are variations in severity. You can also think about psychopathology in terms of the interplay between normality and pathology. So over time, as we develop and as events occur within and to us, we can go back and forth between phases of so-called normal behavior and illness. So psychopathology is not necessarily stable or fixed. nor is it trait-like. It doesn't exist in a person or not exist. It can occur, it can remit, it can relapse, it can change over time. There are also gaps in understanding of psychopathology between the DSM, which, as I said, thinks about mental disorders and categories, and our common parlance, or our everyday language. So in everyday language, we hear people use terms like nervous breakdown that have no corollary in the DSM. Nervous breakdown is not a clinical term. It's not clear what people who use that term mean. The nerves don't break down. What condition do people have in mind when they're talking about that? It is not a meaningful term and you shouldn't use it. There are also gaps in understanding of psychopathology between the DSM classifications and our understanding of developmental psychology. We'll talk more about that in a minute. Here's a quick history of the DSM, which is important because it's very influential in American mental health services. I said that it was developed by the American Psychiatric Association. The first edition of the DSM appeared in 1952 with 106 different diagnostic categories. The DSM-2 appeared in 1968 with 182 diagnoses. It's important to note that this included so-called homosexual disorder. That is, according to the APA, homosexuality was a mental disorder from 1968 until this was changed in 1980. In 1980, the DSM-3 appeared with 265 diagnoses, and the APA began what's called a multi-axial diagnostic system. I'll explain that in a minute. The DSM-3 was revised in 1987 with 292 diagnoses. The DSM-4 appeared in 1994 with almost 300 diagnoses. And the text was revised, although diagnostic categories were not changed, in 2000. And then importantly, the DSM-5 appeared in 2013. Now the multi-axial system has been dropped, and there are 20 chapters on disorders. The DSM-5 includes 15 new disorders, and some of the old disorders have been dropped. It's important to say that this is not the only classification system for mental disorders. The World Health Organization's International Classification of Diseases, the ICD, is more commonly used than the DSM outside of the USA. So here's some major changes in the DSM-5. I said that the multi-axial assessment that was present in the DSM-3 and DSM-4 has been dropped. What does that mean? Well, in the multi-axial assessment called for assessment on 5 axes. The first axis, or major category of disorder, were the acute mental disorders, such as mood disorder, anxiety disorder. These are disorders that can change over time. That's why they're called acute. The second axis contains personality disorders that are thought to be more stable and fixed and less likely to change over time. So narcissistic personality disorder, antisocial personality disorder, and other personality disorders are diagnosed on axis 2. Axis 3 contains medical conditions, and it was important in the multi-axial system to distinguish disorders on axis 1, 2, and 3. But now these axes have been combined in DSM-5 to remove, quote, artificial distinctions between mental and medical disorders. It's a major change. However, categorical approach to diagnosis, which is retained in DSM-5, is supplemented by notations on psychosocial and contextual factors that were formerly called axis 4, and notations on disabilities, formerly diagnosed on axis 5. And there is now a severity dimension, or rating. Here are some specific changes in the DSM-5. Autism spectrum disorder, or ASD, has replaced 4 separate diagnostic categories. Childhood bipolar disorder has been renamed disruptive mood dysregulation disorder to deal with the overdiagnosis of bipolar disorder in children. Bereavement is no longer an exclusion for major depression. So So it used to be that within a few months after the loss of a loved one, somebody who was grieving would be considered to be in bereavement, not depressed. That is no longer the case. So now, after the loss of a loved one, grief can be considered depression. I'll let you read the other major changes here. The question is about the reliability of DSM diagnoses. For most of the DSM diagnoses, inter-rater or inter-observer reliability, that is agreement, is low. So this means that two clinicians looking at the same person may well come up with different diagnoses. There's an old joke. How many different diagnoses will you get if you see 10 different psychiatrists? And the answer is 12. Because some of these clinicians will make a dual diagnosis, giving you two labels. That's a problem. And the problem with reliability of diagnoses is in part related to the fact that people have different training and come at diagnostic criteria with different perspectives. So different theoretical perspectives influence what we see. What you choose to name it depends on how you frame it, how you understand human behavior in the social environment. The DSM, however, is atheoretical. These diagnoses are supposed to be based on observable signs and reportable symptoms. The DSM is not related to any particular theory of human behavior or human development, and it is not a guide to treatment. In thinking about psychopathology, we also have to look at the flip side. What is normal? Well, there's a wide range of so-called normal. Typical is actually probably a better word here. In fact, diversity is the norm. There's a fine line between normal and abnormal, and this line is drawn in different ways in different cultures, contexts, and time. So what is considered normal or typical in one culture might be considered abnormal in another. Normal behavior in one context might be out of place in another, and our norms change over time. So we get a better understanding of normal development by studying deviations. And we get a better understanding of deviations, psychopathology, in normal developmental contexts. It's two sides of the same coin. It's important to note the trend toward medicalization and marketing of mental disorders. Ray Moynihan has said that the people drawing the line between normal and abnormal have drug company pens in their hands. There's a lot of evidence for that. In fact, most of the members of the DSM-5 task forces, the people responsible for defining disorders, have clear financial ties to pharmaceutical companies. Please take a look at Ray Moynihan's talk based on his book, Sex, Lies, and Pharmaceuticals. The YouTube link is shown here and also provided in your Moodle course shell. Please take a look at this talk. It's an excellent example of the medicalization and marketing of mental disorders. It's very disturbing. So in developmental psychology and developmental psychopathology, adaptive and maladaptive behavior has to be understood in its context, that is in its culture, along with social expectations and prior history, individual history. We have to understand that behavior and cognition, that is thinking, change over time, and our interpretation of behavior changes over time. So the same actions and statements made by an infant and an adolescent are going to be interpreted very differently. Factors that potentiate, maintain, and disrupt adaptive or maladaptive behavior also change over time across contexts with changes in our social environment. So we have to understand maladaptive behavior in developmental context. What is appropriate for a given stage or phase of development? This changes over time. A behavior that might have had real adaptive value at one point in time might have been learned and become habitual can easily be maladaptive in another context. So the study of development and developmental psychopathology is quite complex, and Samaroff's article describes this biopsychosocial ecological systems model of development. In this model, Samaroff is trying to be very holistic and encompassing many influences on human development. He uses a multi-level or multiple-level approach to analysis. What does this mean? Well, this takes us back to the ecological model of Urie Bronfenbrenner, and again, we're looking at multiple system levels, looking at the individual microsystems, mesosystems, macrosystems. Okay, so biopsychosocial ecological systems models are taking into account all systems levels. We're also looking at multiple domains. So what does that mean? What's included? Well, we're looking at different domains of development, including language, cognition, emotion, emotional regulation, social development, physical development, and so on. There's not much that's excluded here. We also have to take into account bidirectional or two-way influences among genes, neurobiology, behavior, and the environment. So, for example, thoughts and emotions influence our biochemical functioning and vice versa. We also recognize that there are shifts in development over time. So time is a major factor here, that we become organized to do certain things, and then those patterns may not serve us well. We become disorganized, and there's a reorganization of organs and systems. So, for example, families become organized to take care of young children. And as those children grow, the systems that families develop to care for them, such as reading children's stories at night, don't work anymore. That doesn't work very well for adolescents. And so that system falls apart, becomes disorganized, and families come up with new ways of organizing themselves to meet the needs of their current members. Developmental processes are described by Samaroff as dialectical. There are pathways or cascades in development, and diverse factors initiate, maintain, and disrupt progress along those developmental pathways. Those cascades can be cascades sort of upwards, improvement in some functions, or downwards, deterioration in some functions. This next point is really important for us. Behavior is multiply determined. The influences on human behavior are many. There are few, if any, single causes of behavior and human outcomes. But there are constraints on how much diversity is possible. Not all paths or outcomes are equally likely from different starting points. So your starting point does constrain the outcomes to some extent. Not all things are possible. Here's another way to think about it. Development involves both of these processes of equifinality and multifinality. So equifinality, equa means equal, finality means ends, is shown in the diagram on the left. And it means that you can have several different starting points that lead to the same outcomes, equal ends from different starting points. One example that I can think of is the outcome of physical child abuse. That can result from a variety of different factors. So physical child abuse, outcome X, could be caused by severe parental stress, perhaps associated with job loss or poverty. It could be the result of serious parental mental illness. It could be the result of substance abuse. So those are three different starting points and three different pathways to the same outcome, equifinality. Multifinality, multiple ends, it happens at the same time. So this is where we have one starting point with 3 different paths leading to 3 different outcomes. So let's take the case of, child abuse again. Take 3 children physically abused in the same family. They can have 3 different outcomes. Same starting point. One child may go on to repeat the kind of care that she received physically abusing her kids. Another sibling might go on to become much more severe in her treatment of children, seriously injuring or even killing her kids. And a third might decide that this is not the pattern she wants to repeat and may end up treating her children very gently. So same family, different siblings, different outcomes. We've talked about risk and protective factors before. Here's a formal definition. Risk factors increase the likelihood of a negative outcome. Protective factors increase the likelihood of a positive outcome. And risk factors have additive and exponential effects. They build on each other, and at a certain point, with 3 or 4 risk factors present, the likelihood of a negative outcome becomes increasingly great. We also talk about risk bundles. Risk factors occur in bundles, and as you probably know, the largest single bundle of risk factors is associated with poverty, which involves lack of access to adequate medical care, nutrition, schooling, safe environments, a bundle of risks. Now, protective factors counterbalance risks. Promotive factors have positive effects in both high and low risk groups. Let's distinguish correlates from causes here. So risk factors are associated, that is correlated, with certain outcomes, but that does not mean that they are causes. They may not be causes. Causality requires 3 conditions. The cause and effect have to be correlated. They have to occur together. They have to occur in a certain sequence or time order. That is, the cause has to happen before the effect. And we have to be able to rule out other explanations, third variables, for the effect. Now, risk factors are correlated with outcomes, and they do come before the outcomes, but they don't meet the third requirement for causal inference. They don't necessarily rule out other possible explanations. So what do we know about development now? Change over time. We've said that it's epigenetic, unfolding according to a plan. This is a probabilistic plan. Things are likely to happen in certain ways. It's not predetermined. Development involves increasing complexity in terms of structures, functions, and competencies at all levels of development. A major pattern is differentiation and hierarchical integration or organization. So, for example, I mentioned vocabulary and sentence construction become increasingly specific, differentiated, and sophisticated. There is also a recycling of issues. There are certain themes that keep reoccurring in human development. So, for example, our representations of the world are important issues, and we have certain ways of representing the world, understanding the world, that change over time, but this keeps coming up. So infants are learning about the world in certain ways. Young children are learning about and representing the world in other ways, often through art, and adolescents and adults also grapple with these issues. Another recurring issue is identity. How we think about ourselves, who we are, keeps coming up. And of course, human relationships are important issues that keep coming up throughout our lifespan. So we see emerging functions, competencies, and developmental tasks that modify behaviors and disorders. Resilience is an interesting idea. Resilience is defined by Cecchetti as the competent adaptation despite the presence of chronic adversity or exposure to prolonged or severe trauma. It's not static. It can change over time within a person. It's not trait-like. It's not something that you have or don't. Resilience is something we don't understand well, but we know that 2 different people going through the same chronic adversity or trauma are likely to respond different ways with more or less resilience. Cultural norms determine what is normal, and culture affects our behavior, expression of emotion, and symptoms. Culture affects interpretations and meanings of behavior. Here are a couple of my favorite quotes from Cicchetti. He said, "Clearly, no behavior or pattern of adaptation can be viewed as pathological except in particular contexts." Here's another longer quote that I'll let you read on your own. Let's think about prevention and intervention now in terms of development and psychopathology. We need to bridge basic, that is theoretical, and applied research to do this well. What we want to do is reduce maladaptation, reduce psychopathology, and promote competence. To do this, we want to reduce risk factors and promote protective factors. That is basically what social work is trying to do. Reduce risk factors and promote protective factors. Can you think of some examples of how we do this? Or how we can do this? Let's look at Samaroff's unified theory. He gives us this ice cream cone in a can model of self and other regulation. And what's going on here is that the horizontal axis is time, and he's showing that over time we increase our self-regulation and become less dependent on others to care for us and do things for us. But this is not a simple sort of linear progression. It happens in phases. Over time, we become increasingly more able to self-regulate. Samaroff talks about personal change, context, regulation, and representational models. What are the social constructions that appear in these models? Here's some references for further reading or viewing. I'm not suggesting that you go read these this semester, but just for your information for later. That's all for now.